Thank you.
Thanks, Tim. And welcome. So glad you're all here with us today. I'm thrilled to have Dr. Kelly Myrich join me today for this presentation. Dr. Myrich is a clinical psychologist working for the National Center for PTSD as the director of their PTSD mentoring program. The program is comprised of a network of leaders within PTSD specialty care in the Department of Veterans Affairs. She's also a national trainer and consultant for CPT and has served as a therapist, investigator, and adherence and competence rater for several clinical research trials involving CPT. And I am Dr. Ellen Healy, and I'm a clinical psychologist, and I am the Training and Education Coordinator for the VA CPT training program. In this role, I'm a national CPT trainer and consultant, and I also coordinate our CPT regional trainers who lead CPT trainings locally. I'm at VA Boston, and I'm an affiliate of the Women's Health Science Division of the National Center for PTSD. I'm thrilled to be here today. I'm going to get us started, and then I will pass it over to Dr. Myrich in a little while. And as Tim mentioned, we'll save some time for questions at the end. So our objectives for today's talk are to identify the impact of measurement-based care on providers and patients, and then to describe how CPT incorporates measurement-based care, and lastly, to demonstrate methods for how to collect, share, act measurement when providing CPT. And to get us started, before we dive in, we're going to start with a poll question, get the juices flowing a little bit. So what are your thoughts about how can measurement-based care enhance the provision of CPT for providers and patients from what you know coming in? Take a moment and enter in a free response, so you can just fill in an answer there. So I'll give you all a moment and see what you have to say. Awesome. I'm seeing some themes around tracking progress, opportunities to look for stuck points, noticing when patients are stuck or not improving. Yes, all of these things are things that we're going to be talking about today. Awesome. Lots of great answers here. Visual evidence to show the patient that they're getting better or seeing their progress. Absolutely. I see a big theme around tracking progress. Awesome. Great. Thanks for your thoughts there, and we'll pull that to the side now. So you guys are on the right track. You know what we're talking about today. All right. So first we're going to start with a definition of what is measurement-based care. Measurement-based care entails the systematic administration of symptom rating scales and uses results to drive clinical decision-making at the level of the individual patient. And by measuring symptoms throughout treatment, it increases the likelihood of detecting treatment non-response, and this assessment provides information that can inform treatment plan decisions and focus of treatment. Oops, I went too far. Okay. Measurement-based care entails three principles that we're going to then apply to CPT. But in general, first, we've got collect, share, act as the three principles of measurement-based care. First, collect involves administering reliable, validated self-report measures at regular intervals routinely throughout care. Then second, we have share, which means providing the veteran and other clinicians involved in the veteran's care feedback to inform clinical care and shared decision-making. And third, we have act. And this means using information gathered from these assessments to make decisions about care together with the veteran to individualize ongoing treatment with the goal of improving results. So measurement-based care impacts both providers and patients. And so it's helpful to think about this from both perspectives. So for providers, the information gained when using measurement can help us as providers consider the need to potentially change a treatment plan. It allows providers to detect symptom increases that might need addressing or detect residual symptoms that might need additional intervention. It also allows the provider to quantify how much patients are improving, which can then inform whether additional treatment is needed, changes in focus of treatment are needed, or whether treatment goals have been reached. From a patient perspective, measurement-based care provides the opportunity for patients to communicate symptoms to providers. And these have the possibility of being overlooked if we're not directly asking about it. Also, when patients get feedback, it can help patients attune to their current symptoms and recognize if they're improving. It can also help patients participate in shared decision-making processes when measures are discussed and taken into account when considering the next steps in treatment. So now we're going to turn our attention to the intersection of measurement-based care and CPT. So as most of you know, measurement is in fact integral to CPT. But today we're going to dive in to look at how to maximize the use of that measurement when we're delivering CPT. So first off, we want to make sure that we're using assessment to inform our initial determination of the diagnosis of PTSD, as well as any comorbid disorders. And then assessment occurs at a frequent and regular intervals throughout treatment, most typically weekly, to track symptom progress. So in CPT, we always include the PCL to track PTSD symptoms, and we recommend providing the PHQ-9 to track depressive symptoms, especially when depression is a concern. You may also consider other weekly measures to assess a comorbid condition, such as substance abuse monitoring, for example. Measures should be administered weekly, and so if sessions are occurring more frequently than weekly, twice a week, for example, then the PCL should still be administered once per week. And so it's important that we're providing informed consent and discussing why we're collecting the measures. So talking about what will measurement tell us, how will it inform your care, talking about how assessments can direct our focus. It also can be a hint to us if we're missing something, if scores aren't coming down. And so you're going to want to, as part of that orientation to the use of measurement in CPT, emphasize that measures are truly a part of the treatment. And it's a way for the patient to communicate what they're experiencing and a way for us to track their progress, which in turn helps us inform clinical decisions. Clinicians should orient patients to the logistics of measurement completion and discuss that they'll be asked to complete them each week so they know what to prepare for, and make sure to clarify the purpose and the time frame for the measure. So, for example, with the PCL, we want to make sure that we're assessing PTSD symptoms that are anchored to a particular trauma versus capturing general distress, so reminding folks to anchor it to a trauma. Also making sure that they're thinking about the time frame that the measure is asking for, so orienting them to anchor their response to the past week, for example. We want to remind them to take their time and fill it out carefully. I also find that as time goes by, it can be helpful to remind patients as they're filling out the PCL to fill it out on the same scale or with the same calibration as when they started treatment. So if they are endorsing a symptom at an extremely bothersome level, is it still at that same extremely bothersome level that it was before, or is it less than that? So helping them really think about kind of keeping that calibrated across measures, or measure administration, rather. So one common question that comes up a lot as we're getting started with measurement in the course of CPT is concerns about the impact of measurement-based care on service connection for PTSD in particular. And so it's important to remind veterans that service connection determinations and treatment are separate processes. The therapist you as the therapist don't make any of the decisions related to service connection ratings, and that can be important to reiterate. It's also important to have discussions with a veteran about why they're here for treatment. So our focus is on improving their quality of life, and that's what we want to make sure that we're on the same page, that that's what we're actively working towards together. The use of analogies can be helpful. In this case, a helpful analogy could be if you were service-connected for heart disease, wouldn't you want your doctor to measure how you're functioning? Sometimes those parallels with the medical side of things can be helpful. We also want to explore their concerns about service connection and provide information to clarify any misunderstandings. There's been some investigations that VBA and VHA have done looking at the data around service connection, and it's actually very, very rare that reductions and decreases in payment or alterations in service connection status happen. And so when they looked, it was well under 1% of the cases that were reviewed. And when there are reductions, it most often is to the next step down, so like 70% to 50%, 50 to 30, but it's really exceedingly rare to sever service connection altogether. And so getting some of that data can be helpful for folks. And so to clarify some of those misconceptions, but at the same time also validating concerns about what would happen if they had a financial reduction, and making sure that their goals and your goals align, and that it's the right time for CPT, and that truly they really want to improve their PTSD symptoms, and making sure you guys are working towards the same thing. Also, that VBA doesn't randomly look at veterans' treatment records. It's only if there's a standard review scheduled, typically only after 5 years after that initial service connection, or they will look at treatment records if the veteran is currently filing for an increase. So in that situation, VBA would be looking at the records. So, wanting to balance what is, potentially valid concerns, but also with as much accurate, data-driven information about it as possible, so that folks can make an informed decision about whether it's the right time to do CPT. All right, so our primary outcome measure in CPT is the PCL-5, as you all know. It measures PTSD symptoms and maps onto the DSM-5 criteria for PTSD. It has 20 items that are rated on a Likert scale from 0 to 4 for a total score ranging from 0 to This differs from the earlier version of the PCL based on the DSM-4, which had a scale of 1 to 5. And so the scores on the two measures, and there's a different number of items as well, so the scores on the two measures are not interchangeable. This doesn't come up as an issue as much anymore, given the PCL-5 has been around for some time now, but it's important to remember if you're ever looking at historical clinic data or older data from your clinic that those scores don't correspond to one another. So there's monthly and weekly versions of the PCL, and the most recent validation studies of the PCL point to a cut score for determining a probable diagnosis of PTSD at a score of 31 to 33. So that's typically the low end of the range that we'd be looking at for considering starting CPT with someone. Now, we do at times offer CPT to folks who have subthreshold PTSD, and I'll talk in just a minute about some of the considerations if you're seeing lower scores. Also, for early completer status, when you're considering whether someone might be ready to complete CPT early before 12 sessions, we'd want to see a PCL of 18 or below to consider someone to be considered for an early completion of CPT. Of course, for early completion, there's more than just the scores. We want to make sure both the therapist and the client feel ready and that makes sense. So, but that is one, the PCL is one important piece of information to that decision. The PHQ-9 is the depression measure of choice in VA, and it has 9 items and is rated on a scale from 0 to 3 for a total score ranging from 0 to 27. Increasing scores reflect increased depression severity. And so for CPT, as I mentioned before, we encourage the use of the PHQ-9 anytime there's depressive symptoms to monitor. So now we're going to, that sort of set the stage, and now we're thinking about when we're actually collecting the measures. And so we're going to now think about these different phases of measurement-based care, or the principles of measurement-based care, rather. So we'll start with that first phase, collect. So it's important to think about in advance when we're thinking about collecting measures, the logistics involved in administering measures, thinking about how they're going to be administered, paper and pencil, and then entering into mental health assistant after the fact, or using mental health assistant in the kiosk mode, or behavioral health lab on the iPads. You want to figure out who will administer and the location where the measurement will be collected. Will it be by a clerk or a nurse in the waiting room? Are you going to leave measures out in advance of the session, or are you going to deliver it to the patient? Will you ask them to do it in the office? So all of these are things to think about. If you're doing CPT via VVC, telehealth, there are other logistics there to think about in terms of how the measures, how to get the measures to the veteran and making sure to plan for that in advance. Oh, I see some questions about home to home. Kelly, are you more familiar with BHL? I haven't used it myself.
I am familiar, but I'm also in the position of not having actually used it on my own. I know there's a lot of different functioning. I believe that at this point, BHL for VVC appointments, the patient would have to have access to the type of iPad that would be compatible with BHL, but I see Karen Thompson typing right now, and I know she's had some experience with that. So why don't we have folks keep typing questions, and we'll circle back to that at the end and respond.
Sounds good. Thanks. Okay, so the measurement-based care in CPT relies on patient-reported outcomes, and so it's really important for us to be assessing the validity of what patients are reporting. And so you want to consider the client's state when they're completing measures. Are they intoxicated, overly tired, exhausted? Is that impacting how they're filling it out? Also making sure that if they're oriented to non-trauma related stress rather than anchoring the PCL to the trauma experience can also impact the scores. So for example, if someone had a, say, fight with their significant other and they're referencing that when they're rating items involving repeated disturbing unwanted memories or feeling very upset when reminded of a stressful experience, if that's what they're referencing, then it wouldn't be a valid depiction of PTSD on the PCL, and rather more capturing general distress or distress related to those recent stressors. So that can be an important thing to look for. Also looking for patterns across sessions. So are they reporting consistently high scores across sessions, low scores? Is it never changing? Sort of keeping your eye out for those patterns, and is the way that they're reporting, how consistent is that with the other things they're saying to you, what they're reporting about their symptoms, what they're saying about how difficult of a time they are having functioning in their life? You know, how well does that seem to correspond with what they're putting on the PCL? So in terms of lower scores, when we want to make sure we have an accurate diagnosis. That's an important starting place for CPT. And we want to make sure that so that patients have PTSD or subthreshold PTSD in some cases before we start. So if that PCL is low, so if we're looking at a PCL that looks lower than 31 to 33, there's a few things that you want to think about. You want to make sure that the traumatic experience that they're referencing or that they're reporting meets DSM-5 criterion A for a PTSD diagnosis. Sometimes what patients define as traumatic experiences in their own minds doesn't meet what's considered a trauma as far as the DSM diagnosis, and so that's one important thing. We really want to make sure that there's a traumatic experience that would be the focus of treatment that meets that criteria. Also, are the symptoms, are there symptoms in each symptom cluster? So are we seeing, does it generally look like PTSD? Are we seeing a range? Are we seeing avoidance? Are we seeing hyperarousal symptoms and re-experiencing symptoms? And if not, then we might be talking about a different diagnosis, in which case a different therapy might be appropriate, because not everyone who's experienced trauma has PTSD or needs CPT. So these are things we want to be thinking about. And lastly, are you hearing stuck points? Are you hearing things where you can see that there's a target for CPT, especially assimilated stuck points? If I have someone who has a relatively low PCL, but I am hearing so many self-blame stuck points, it's so clear that there's a real clear target there of treatment, then I'd be more apt to think that CPT was a good fit and proceed accordingly. If you're not hearing stuck points, even if like the trauma seems like it sounds very horrific and you'd think this person must have PTSD even though they're reporting very low symptoms, but you're not hearing stuck points or what sounds like could be stuck points, then it may not be the right treatment for them. The other thing is we know that folks sometimes approach these assessments, especially initially, with avoidance, because we know avoidance is a big part of PTSD. And so sometimes we'll see folks with a relatively low PCL to start with, and as we get started, then you see those symptoms go up a little as they're avoiding less, and maybe looks a little more and corresponds more to what they are saying that they are experiencing, versus maybe initially their PCL looked lower than you would have expected given what they had been describing. All right. So given that there are times that there's discrepancies between what you're seeing in the patient and what they're reporting on the PCL or in various other patterns that you might be noticing, what stuck points, thinking about this from a CPT perspective, have you heard from patients that might interfere with measurement accuracy? So this is another free response poll question here. And just go ahead and type in some thoughts. I'll give you a moment. But thinking about what do you hear from patients and what might be stuck points that you want to target that might be impacting how they're filling out their measurements? All right, great. So I see the service connection there. The government can't be trusted. It's weak to be vulnerable, so stuck points about what it means to be sharing what's really going on with them. Maybe no treatment will work, so why bother telling you what's really going on? I can't recover. I shouldn't be so upset about this, so that's a good one, right? So if there's stuck points around minimizing their distress and maybe not wanting to convey what their level of distress is. And folks can see these popping up on the screen, right? I'll scroll down so you can see a few more. These are great ideas. I don't trust this will work. I can't recover. So yeah, there's a lot of different ideas there. And so these are all stuck points that if you're seeing some discrepancies in how folks are filling things out, then these are stuck points to keep an eye out for, and then we can target these stuck points so that we can get a better picture of what's going on. All right, great. I'm going to move that poll out of the way. So some of the themes that you all just shared, you might see stuck points about what it means to be measured or to be tracked in terms of I can't trust anyone, people are out to get me, or I can't fill this out without being triggered. Sometimes there's a lot of thoughts about that it will just be distressing in and of itself to fill this out. And also thoughts about progress, like what it means to get better. And if I get better, it means maybe that the trauma wasn't important or that I can't get better. So those are some themes of stuck points to keep an eye out for. All right, so that brings us to share, the next principle in measurement-based care. And at this point, I'm going to pass it over to Dr. Myrich.
Thank you, Dr. Healy.
Yes.
So I've spent a lot of time talking with people about the collect focus of measurement-based care, and this is, I think, really interesting to also highlight the share, and then in a second I'll highlight act, because this is often, I think, one of the missed areas. We tend to focus so much on how to get the measurement, and then at times we end up missing what we're supposed to do with the measurement. So as I mentioned, this is a key component, and I think what makes it so important and key is that it really is a collaborative step in this process between the patient and the provider sharing information bidirectionally, and that the patient's giving you key information via the measurement, and the provider is paying attention to that information in a number of different ways. There certainly are a lot of options for how you can take the measurement that is being collected and shared by the patient in reviewing and discussing that with the patient. I'm going to go over just a couple of different ways, but feel free to chat in if you have other ways that you have kind of in best practice been able to really talk about the measurement that the patient is completing. So first I want to talk a little bit about sort of looking at the total score. One of the things that we can do is help our patients sometimes who need to kind of visually see information. Obviously in CPT we have a lot of different visual tools with our worksheets, but another way that we can communicate and share the measurement and the information that's collected is actually by graphing out the total score. By doing this, sometimes it allows us to use that total score to demonstrate the congruency with the treatment expectations at different points in treatment. If you look at the example there of the female MST patient, one of the things I've often done is I've talked during the psychoeducational component of CPT about what the patient might expect during the course of treatment. And one of the things that we note is that in terms of their experience of their symptoms, that there's a possibility, again, not 100%, but a possibility that they may experience an increase in their symptoms before they see a decrease. I often draw that on the board and refer to it as the hump. I've multiple times when doing CPT had patients like the female patient who at session 4 was watching her scores go up, and I reminded her from the information I shared with her in session 1 about that hump and that expectation that we might see an increase before we see a decrease. And in fact, I even said, where do you think you might be on that hump? Do you think we maybe are getting close, or do you think there's something else that we might need to be focusing on to make sure we get you over that hump? Also, I think using the PCL early helps you to recognize if there are things that maybe you otherwise wouldn't be capturing in terms of response or rather non-response. So if you look at our male combat veteran here, first of all, I'd love to see any patient be that consistent. But if I'm seeing after 4 weeks in a row the exact same score, that's probably going to raise some questions that I'm going to want to then discuss with my patient about what this measurement's telling us about their reactions to treatment. And in particular, also, I know a lot of cases where it's later in treatment that maybe people pay attention to the measurement, when in fact early in treatment, it's an opportunity to begin that discussion about key factors like treatment engagement, goal alignment, and things of that nature. But you also can sort of do a much more specific dive in and look at individual items. By reviewing the individual items, it allows you to sort of talk very specifically about which areas may be making improvement and which may be more resistant or potentially more stuck. I also think that this allows you to compare and contrast what you're hearing from your patient at other times in the session as they're talking about their daily life, talking about their implementation of hopefully the practice assignment, and what you're actually seeing on the PCL. So for example, I pretty regularly will go to the items on avoidance, so either number 4, the feelings that you may have, or physical reactions, or number 7 and number 6 and number 7 for avoidance. I was going to choose a different example today, and that's actually number 4, which is having that sort of strong emotional reaction when you're reminded of a stressful experience. CPT is a trauma-focused treatment, whether you're doing CPT or CPTA, and if you're talking about those details of the trauma, your Socratic dialogue, as you're working on stuff points, you also want to be watching for changes in their emotional reactivity to that discussion. And if in session you're starting to see potentially a reduction of that distress, you want to check and use the PCL as another way to say, are you sure that your reaction is still really extremely, or have you noticed that you're becoming more and more able to talk about this and you may be experiencing less distress? Now, that may be true or false, but this is how measurement allows you to check in and check that assumption that what they're saying on the PCL actually matches their internal experience. Of course, also in CPT, we can focus on some specific items that we know relate to the nature of this treatment, and in particular, those are items 10 and 11, with 10 being focused on the cognition of blame, either for yourself or someone else for exactly what happened, so that helps us target those assimilated stuck points of blame. And then number 11, I love that this item was broadened with DSM-5, but I think it's also important that when you have someone circle on this, I like to follow up with which emotion are they having, and maybe they're still having a lot of anger, but their guilt's reducing, or vice versa. So again, this individual item discussion allows you to drill in and have a deeper discussion about what the patient's telling you with these measurements. One of the things that often comes up when I talk about measure-based care is that this measurement doesn't capture all the things that we need to do in clinical care. And my answer to that is you are correct. Measurement is only one source of information during CPT, and you have to continue to gather other sources and use all of those sources when you're using the information to ultimately update your case conceptualization and treatment plan, or the ACT component of measure-based care. So we have to continue to look for that ongoing report of other psychosocial factors that we know can have a strong influence on treatment in many ways. Also, you want to look at the session content of what's happening each session, the degree of engagement, whether that's via practice assignment or frankly just being able to be present during the session and not distracted by other psychosocial factors. Also, comprehension and implementation of CPT concepts. Right, comprehension. I know people who do a lot of worksheets that do not get what those worksheets are actually intending to accomplish. And similarly, I know a lot of people that can do some of those worksheets, but then we don't see the translation of some of those cognitive skills into their actual daily life. So talking about measurement might be something that people are also comfortable with, but actually acting on the measurement is another step that I think at times can be challenging, in part because we're still gathering information about how to make some of these decisions in regards to the information we're gathering from measurement-based care. I would argue that, as we're doing this data collection and we're talking with our patients about the information, we have to keep several questions in mind. And I think these questions are important, not just when you're getting close to what you air quote would call the end of treatment, but throughout the entire episode of care. The first question being, has this treatment been successfully completed? There's a lot of different ways that we can define success. I'll talk about a few here in a minute. But I will say that attending sessions and attending all 12 sessions and doing worksheets does not necessarily mean that someone has successfully completed a course of treatment. I think it's also important, along with that question, to ask, were the treatment objectives met? What were the treatment objectives? We can talk about what CPT as a treatment is designed to target, but did that align with what the patient was actually identifying as their goals for treatment? And were those goals aligned with what the provider was also trying to accomplish? It's hard to meet an objective when people aren't necessarily working towards the same objective. Also, have there been new needs identified? Treatment doesn't happen in a vacuum. People are still living their lives while they're completing CPT, and there are new things that can come up, as well as things that maybe weren't as much of an issue, but are now coming to the forefront. So have the current needs of treatment changed? Is something else now a bigger priority because of, again, a number of things that happen in that patient's life during the course of treatment? Has progress stalled? Many of us probably have an internal sense as clinicians that we feel like things are stalling out, or maybe we could even call that, has progress gotten stuck? We like that term in CPT. But I think it's important to recognize that being adherent to CPT is obviously moving forward and not getting stuck, but sometimes we're moving forward, but we're not really advancing the treatment. And last but not least, this is honestly one of my favorites, and I bring it up in consultation regularly. Have you actually really initiated CPT? I use this example for a lot of veterans and patients, even outside of the VA, that sometimes when we start a course of CPT, with it being an evidence-based treatment, but also a protocol-oriented treatment, that we're told to kind of move forward each session and address avoidance as it goes. But I've known many people to get through session 1, session 2, session 3, and they're still spending the majority of that session going over treatment rationale, talking the patient into this treatment, and watching the patient doing more questioning, and not of the Socratic kind, but questioning whether the treatment's even something they want to do, and not really even doing it as a practice assignment. At that point, have you really actually started CPT, or are you acknowledging that maybe this wasn't the treatment that that patient really wanted to engage in the first place? In terms of sort of successful completion, this is, I think, the picture that many of us have in mind as we're trying to implement this treatment. And it certainly has been the standard expectation as CPT was developed that there would be a course of 12 sessions of care, and that ideally, we might see different patterns. Sometimes, steady progress, that at some point you might see a more dramatic decrease like our female in the 50s, Or potentially, like I mentioned, someone who has that sort of slight increase early in CPT and then sort of a slow and steady decrease throughout the course. But in these two cases, we're getting to the end of treatment, right? We're getting to that 12 session as CPT was designed. But maybe measurement-based care also can help us start to think about what does a course of CPT look like? Does it always have to be 12 sessions? Can it be earlier? Can it be shorter? But let's say these are your patients and don't pay attention to anything from session 7 over. If you have this female who is at session 6 and she's got, what, probably a PCL of a 62, and you've got your male over there who's got a PCL of under 62, maybe right around 56, all right? What are you going to start saying to that patient if halfway through treatment you're still seeing their PCL up there? Let's give you some options and see what maybe you might say to this patient in that sort of share component of talking about the measurement. Let's go ahead and pull that poll question up. This time, we're not going to necessarily have us type in whatever you want. I'm sure many of you will have lots of interesting things that you would want to say. But we're going to give you some options. Go ahead and check all that apply. But if the PCL is not necessarily improving by mid-treatment, what might you say to your patient? It's a good number of people on the call, so I'll give you some time to respond. I see a lot of people like the first option. Are there any aspects of your trauma that you've avoided talking about? Excellent. Or potentially other traumas. It is definitely not uncommon for patients to present, especially when we're doing an initial evaluation, identify one trauma, but once they get over that initial hump of talking about it, realize there might be something else that actually is more central. Also, many of you highlighted those stock points about getting better, so maybe asking them Socratically, what would it mean to get better from PTSD? And that could potentially uncover some of those stock points that you identified earlier. And here's your graph of scores. This does not reflect a lot of change. Is that how it feels? I like this item a lot too because it's not just assuming the score is 100% accurate, it's checking the accuracy with the actual patient. And looks like none of you took us up on the other two items. Why aren't you working harder? Not necessarily probably the most clinical question that we want to pose. And definitely we don't want to throw the baby out with the bathwater. If there are issues with the assessment, we don't necessarily want to A, disparage the assessment, and B, we don't want to necessarily stop without first assessing what might be going on. All right, thank you. We'll go ahead and clear that poll. So before we actually take the information and start acting and making some potential changes to the treatment plan, there are some things I definitely want to encourage everyone to consider as another layer to this sort of understanding the information you're collecting with measure-based care. And one, I think, with CPT is we definitely want to consider the degree of adherence to treatment, or as I like to put it, what change would be expected if they aren't actually completing the treatment. If you know there are things that are impacting the provision of CPT, then you probably would likely expect to not necessarily see as much progress. That's one potential reason why, not the only. But a couple of things that I think we can highlight when we're talking about adherence to treatment are both from the patient as well as the provider side. Right? So frequency of sessions. We know from research and the work of Cassidy Gunter and her colleagues that the frequency of sessions plays a key role. If patients are coming in weekly and they're able to engage consistently in that treatment, they have a higher chance of experience benefit. I put no-shows and cancellations here because I think on the provider end of this, you know, the patient has to show up, but we also have to hold them accountable for maintaining a consistent episode of care with frequency of sessions. We know no-shows and cancellations can happen for a number of reasons, and they also impact the course of care. Completion of practice assignments. I believe there's still a tutorial that is up on our website that I did several years ago that was called Practice, Practice, Practice. It was not tailored to just talking about how to get patients to do more practice, but it was talking about the quality and making sure that they were using the practice assignments to engage in the therapy and to understand and be able to implement the skills themselves. We know from some work that's going to be published soon by Dr. Wilty Sturman that actually the completion of practice assignments does relate significantly to treatment success. And last but not least, therapist fidelity to protocol. In consultation, this is a routine topic, and there's usually very sincere and good reasons why clinicians want to veer away and then add things to a protocol. And one of the things that I often do in consultation is sort of encourage you to think about what would be the reason for making that change or that deviation, and are you that confident in making that deviation that if then the treatment is not as effective, aka via the measure-based care, are you going to know it's because of CPT or because of the modification you made to it? We also need to really keep an eye on the impact of those ongoing or new psychosocial stressors. A question that I often pose to consultants and have in my mind as a clinician is PTSD really the priority for treatment? If you think about sort of a hierarchy, there are times where absolutely a patient is presenting with a diagnosis of PTSD that may not be their priority. And if that's the case, it may be reflected in their measurement and in the success of that treatment with them. Also, if there are potentially other priorities, have you identified what would be needed to address those stressors so that you could enhance their engagement? Having other priorities, having psychosocial stressors does not automatically mean someone cannot engage in CPT, but it does mean we need to be very conscientious about assessing those and addressing them so that we can increase the enhancement of the CPT provision. And then also we want to evaluate the impact of other secondary factors, right? I mentioned before, making sure that you have progress towards agreed upon goals. Sometimes those goals shift during the course of treatment, and where they may be absolutely on board at session 1, at session 4, I've had many a patient want to deviate. And what that means is it's a good time to use measurement-based care to reassess and talk about that and potentially realign those goals before progressing with the treatment. Also, as many of you probably already know, looking for those opportunities to assess motivation and watching out when it's primarily an extrinsic motivation for treatment. Family is great, and we know that there's a lot of research to suggest that family and social support can help engage in treatment. It can also be a negative if that's the sole motivator for a patient coming into treatment. And as already noted, service connection can certainly play a role with veterans, as that can have sometimes the opposite goal in that CPT is looking to reduce PTSD symptoms as measured by the PCL, whereas service connection is looking at giving you the biggest financial benefit for the degree of dysfunction. I think right now we've got one more. Oh, no, we already did that poll. All right. So let's get to, after you've had all these considerations, you've taken in all of this information, how are you going to use that information to actually update the course of treatment? We know that there's no specific and clear guidance at this point about what exact changes to make exactly when based on exactly what score someone has on a particular treatment. But we do know through science that there are a number of different things to consider, particularly when it comes to CPT. I'm going to give you 3 different sort of examples here to think about how you might take the information from measure-based care and really update and integrate that into your treatment planning. First of all, I would look at circumstances where your measure-based care is indicating minimal change or potentially the scores are increasing. So first of all, consider treatment engagement and adherence early in treatment. I mentioned before, I think it's really important to start taking a look at those patterns early on so that you can get ahead of potentially some patterns that could continue throughout the course of treatment. If early on there's low improvement or you're not seeing much, you're going to want to consider the reasons and discuss those options with the patient and potentially determine an alternate treatment plan if the patient has not even started engaging in CPT. If we're seeing some of those scores increasing, right, some of that may actually meet expectation, but if it's significant enough that it raises to the point of concern for both patient and provider, then maybe we need to ask the question, can the treatment course be improved? We do know that there's some initial data that suggests that actually even increasing the frequency of sessions from weekly to much more frequent, either multiple times a week or in some cases daily, that these mass provision of the protocols where we're taking that treatment and condensing it into a mass application, that can actually sometimes help counteract some of those situations of more significant symptom exacerbation and help that particular patient get through the course of care much more quickly and also get to a more rapid decrease in that distress. Also, many of you, I love your responses in terms of the stuck points, but maybe we need to target some very specific stuck points, right? Those that are maybe related to avoidance, or as I've referred to them before as treatment interfering stuck points. And we also know that sometimes if we're getting away from focusing on assimilated, we need to get right back there, even if that ends up being later in the course of treatment. Also, several of you, I think, caught this in terms of your stuck point, but looking for what might be missing. Is there another trauma? Is there something that hasn't been disclosed within the trauma, but a detail that they haven't told you about yet? Sometimes those key elements can really impact the course of care. Then we have another example, not necessarily those that are slow to change or getting potentially, again, I hate to use the term, but maybe worse. Those that are slow and steady, they're the turtles, they're going to get there eventually. But how do we know that? Well, one, we have to kind of consider, first of all, that there's a possibility that someone, if they're making slow progress, they may actually be able to continue that. Our colleague, Tara Golovsky, has multiple times now looked at this and found that actually there are a subset of our patients that just need a little bit more. And that little bit more can be up to the total of about 18 sessions. I will make a quick note here that adding on sessions of CPT does not mean taking CPT and spreading it out across 18 sessions. It means providing the protocol, and then once you get through all the components and all of the themes, that leaves you additional sessions to sort of repeat, continue the Socratic dialogue, continue to target those stuck points now that you've provided them all the skill sets. Last but not least, we also have on the other end of that continuum from those who are having a much more slower and steady late response, those that might have more of an initial and rapid response to the treatment. Dr. Healy already mentioned that in terms of CPT and particularly within the VA our rollout, that we really consider an early responder being someone who's met the threshold of decreasing that PCL below an 18. We want to kind of take a little bit of a look at what that could look like. You're going to want to see a pretty quick and a pretty steady decline. I would also argue that if you're looking at an early completer, remember measurement-based care, particularly the PCL, is only one component of assessing. I would probably want to look at both their decreases in their scores. I'd want to look at their stuck points. I'd want to look at their utilization of the skills. And I'd also want to look at another potential target for measurement-based care, and that's their level of functioning. If they were to end treatment at that session, do you think that they are going to continue to improve? Have they improved enough? And is that improvement going to translate into a higher level of functioning in their life? But for now, I'll pause. I know many people have been typing while I was staring at these slides. So if we want to circle back, Dr. Healy, and answer questions that have already been posed, or we can answer new ones if people haven't had a chance to pose them yet.
Yeah, I don't think there's too many outstanding questions. There were questions about the VBC, and BHL stands for Behavioral Health Lab, right, Kelly?
Mm-hmm. Yes.
And so that is a program that's on iPads that can be used to do assessments on an iPad. And I just put up a link to the Measurement-Based Care SharePoint site, which thanks to Courtney Worley, who reminded me what a good resource this is to remind you all, and there's some resources related to BHL on there as well. Any other questions before we wrap up? Thanks, Maritza. I see a few folks. Oh, folks are saying thank you. Well, if there's not other questions, if there are other questions, feel free to shoot me an email. But we're thrilled to have you all on the call today. And thank you, Dr. Myrich, for co-leading this with me. Your input is always appreciated, and it's wonderful to hear from you.
Thank you.
And I think that pretty much brings us to the end of the hour. So thanks so much.
Thank
And
you
don't
all.
forget to do the evaluation for your CEUs.